So another concept related to our somatic sensations is referred pain. Referred pain is a pain stimulus that's felt away from the actual area that's causing the pain. Now we're still really trying to find out the entire mechanism behind referred pain, but what we do know about referred pain is that the areas that feel pain and the areas that are affected share the same spinal nerves. So clinically we can actually use referred pain to diagnose certain conditions. One example of this is pain that's felt in this area of the chest and down the left arm to the pinky. Pain from the heart is often referred to these cutaneous areas. One way that we can think about referred pain is that it's much more likely that these areas of the skin will be the cause of the pain more so than the heart. So essentially, these pain signals coming from the same spinal segments are getting confused by the central nervous system. One other example of referred pain is shown here with the liver and the gallbladder. Any type of gallbladder issues can be often felt in the right shoulder. And pain caused by appendicitis will often be referred to the umbilicus. So referred pain is pain that's felt in a different area than the painful stimulus is occurring. The sensory modalities give us the ability to sense different things in the external environment. And the brain helps us to perceive those sensory modalities so that we can understand what that stimulus means. So there's a specific part of the brain that this occurs within, and it is known as the primary somatosensory area. The primary somatosensory cortex can be found in what is known as the postcentral gyrus. This is the specific gyrus shown here, just posterior to the central sulcus. So this region of the brain is responsible for giving us our different sensory sensations that we get from every part of our bodies. So you can see in this picture we've taken a section through the postcentral gyrus, and we've drawn a few body structures up here to show you what parts are associated with which part of the primary somatosensory cortex. So one thing that we can see is that every part of the somatosensory cortex is assigned a different part of our bodies. You can see that right here we have the face, up here we have the hand, we have our arms and our legs and our feet at different parts of this cortex. So what this is showing us is that when we feel some type of sensory information on the hand, this part of our brain is going to be lighting up. When we feel some type of sensory information on the foot, this part of our brain is going to light up. So there's this map that can be found in the somatosensory cortex that can be directly linked to each specific part of our bodies. Now, one of the things that you might have noticed already is that there's a very large portion right here that's devoted to the hands and the face. Now, on top of having each individual part of this mapped to a particular part of the body, certain parts of the body are going to get more surface area than others. So what we can see is that the hands and the face actually have a much larger area than other respective body parts. So what we can infer from this is that we have a lot more receptor density found in the face and in the hands than we can find in the feet, in the knees, the elbows, and the chest. The more receptor density that we have in a particular region, the more sensitive those areas will be, and the more precise our sensations are coming from those areas. And that's why the hands and the face have so much space here. Those are some of our most sensitive areas. So it's much easier to distinguish objects with our eyes closed when we are touching them with our hands rather than when we're touching them with our feet. And this is because there's so much more receptor density with our hands than we have in the feet. So the primary somatosensory area is specifically for somatic sensations that are coming into the brain. But we also will find the primary motor area mapped very similarly. So the primary motor area is also going to have a map of the body that we can find on this particular gyrus. And specifically, the primary motor area is found housed within the precentral gyrus, which is found right in front of the central sulcus, and also right in front of the postcentral gyrus, where we found the primary somatosensory area. Now, instead of this being a sensory area, this is the motor area. So this refers to the motor signals that are sent out for particular areas. So the same thing is true with our primary motor area. The more surface area of the brain that we have devoted to a particular area, the more receptor density we have in that area. And that means that more precise movements can be produced from the hands and the face than the legs and the toes. So the amount of surface area found on the brain is directly correlated with the precision of movements and the receptor density that we can find throughout the body. So the next major topic we're going to touch on is sleep. There are two major stages in sleep. We have REM sleep and non-REM sleep. REM stands for rapid eye movement, and during the REM stage, our eyes are actually rapidly moving. So at the end of a long day, when we're trying to go to sleep, we're going to start with the non-REM sleep, and we're going to transition into REM sleep as we get deeper and deeper into sleep. The REM stage of sleep is referred to as deep sleep, and during this stage is when we dream. So let's compare the physiological responses and the characteristics of the non-REM stage with the physiological characteristics of the REM stage. So non-REM sleep is made up of 4 other stages, but most importantly, we have different physiological changes that occur when we are in the non-REM sleep. One thing that we will see is the physiological responses when we're in non-REM sleep will all reverse when we get into the REM stage. So heart rate, respiratory rate, and blood pressure are all going to decrease when we're entering into the non-REM sleep. And this occurs as we progress through each of these 4 stages. We're going to increasingly relax, and that's going to decrease all of these conditions. However, we maintain a degree of muscle tone when we're in this non-REM sleep. We're still able to move our muscles during the sleep before we have entered the REM stage. But during the REM stage, we're going to have some different changes, and things are going to reverse. So heart rate, blood pressure, and respiratory rate are actually all going to increase when we enter into the REM stage. And we'll also see an increase in body temperature also. So all of these conditions actually reverse when we're in the REM stage. The other major change that we have is we actually will have less muscle tone. So this is going to reverse as well. Skeletal muscle paralysis will actually take hold when we are in REM sleep. So we'll actually lose a lot of muscle tone. So I mentioned that this is the stage where dreaming occurs. And when we are dreaming, we're often doing something very active in our dreams. Now, while we are being very active in our sleep, our brains are actually sending out motor signals to act out the activities that we're doing in our dreams. So it's very important that we actually have skeletal muscle paralysis. Otherwise, we'd actually be acting out all of the actions that we did in our dreams. So decreasing our muscle tone is actually a protective mechanism that we have here in the REM sleep. So decreasing muscle tone and undergoing the skeletal muscle paralysis is one of the characteristics we have of the REM stage, and this is protective. This will keep us protected so that we're not acting out our dreams and hurting ourselves in the middle of the night. Now there are some clinical correlations to sleep. Narcolepsy is one condition we have. Narcolepsy is characterized by an immediate entry into the REM stage. So instead of going through all of our non-REM stages, our bodies just immediately, out of nowhere, jump into the REM stage. Now, for those of you that might have trouble sleeping, it might sound a little nice to be able to just jump right into the REM stage. You can fall asleep a lot faster. But this is not just whenever you're lying down to sleep. This is at all times throughout the day. So this can actually be very dangerous when we're driving. We don't want to be exhibiting REM sleep when we're behind the wheel of a moving vehicle. So this is a very serious condition. Insomnia just refers to our body's inability to obtain an adequate amount of sleep. And sleep apnea is another condition where we actually stop breathing while we're sleeping. So this is a really serious condition. Now there are a couple types of sleep apnea. Some are a little bit more serious than others, but there are some risk factors to sleep apnea. Excessive alcohol use, high blood pressure, and especially obesity are all factors that can contribute to sleep apnea. So when we're sleeping, we'll actually lose some muscle tone in certain muscles in the pharynx. And so the loss of this muscle tone of our skeletal muscles in the throat, that's going to make our muscles a lot softer and cause them to close the airway. So obesity is one risk factor that's really, really serious with sleep apnea. The excess weight that can be found pushing down on the throat when an individual sleeps is actually going to contribute to closing that airway. So often the patient does awake due to a lack of oxygen, but we don't want to be constantly undergoing hypoxia every night. So sleep apnea can often be treated with a CPAP machine. Now we have 2 more concepts in chapter 16, and those are learning and memory, and then we've got one quick slide on language. So let's talk about learning and memory, and then we will finish up with Broca's and Wernicke areas. So I've mentioned in many of my lecture videos that neurons exhibit the characteristic of plasticity, which means that they can sprout new projections and disconnect old projections to form new pathways, and that's how we learn. So the process of learning requires taking in information, consolidating that information, and storing that information. And there's 2 types of memories, short-term memory and long-term memory. Short-term memories last seconds. Long-term memories lasts days to years. So the ability of things that we can fit into our long-term memory is virtually limitless. However, unfortunately, we can forget things. And this is why, after not really thinking about a concept for a very long time, those neuronal pathways get disconnected because our nervous system doesn't feel that we need that connection anymore. So the mechanism of learning is called long-term potentiation. This is our neurons making new projections, forming new pathways with other neurons to make new networks so that we can send signals even faster. Now we have a couple different types of memories as well. We have declarative memory and implicit memory. Declarative memory is what you're all working on right now as you watch this video. This is the memory for learning different facts. So a good example of this is actually learning the term declarative memory and what it means. That is a type of declarative memory. So our names and dates, those are examples of declarative memory. The skill memory, or the implicit memory, refers to our muscle memory. These are skills such as riding a bike, playing a musical instrument, or driving a car. So the implicit memory is actually very difficult to unlearn, and I guess it's rather unfortunate that the declarative memory is not also hard to unlearn. It would be nice if we could learn all this information once and remember it forever, but this is why I always suggest that you take a look at your notes every single day. The more exposure that you have to this material, the better you will remember this information. So some conditions that can affect our abilities to learn are shown right here. So first and foremost is our current emotional state. It's true that during times of stress, we are releasing certain hormones that help us to remember things better. However, if we're not in a good state emotionally, this can actually hinder our ability to move the information in our short-term memory to our long-term memory. Rehearsal is another activity that we can use to transfer short-term memory into long-term memory. So constantly repeating information and exposing yourself to that information more frequently will help to increase your ability to learn that information. And also making associations with new information to old information. Now the last concept for chapter 16 is language, so we're going to just re-explain Broca's area and Wernicke's area on this slide. Broca's area is the area of the cerebral cortex that helps us to produce speech. This area is active when we're thinking of new things to say. So as I record this, my Broca's area is firing. Wernicke's area is going to be active when we're trying to interpret different language. So I can say, I hope that your Wernicke's area is active as you listen to this. So again, we have two types of aphasia, Broca's aphasia and Wernicke's aphasia. If Broca's area is damaged, we're not going to be able to produce speech. We'll still be able to write down our concepts, but we won't be able to put them into words. So with Wernicke's aphasia, if this area of the cerebral cortex is damaged, we're going to have a hard time interpreting different words. So when we hear others speaking in foreign languages, we're not able to make sense of those words. And that's one way that we can look at Wernicke's aphasia. We can hear the words just fine, but we can't make any sense out of them. So with Broca's aphasia, we're still able to comprehend words, we just can't produce those words from our mouth. With Wernicke's aphasia, we're still able to speak, but we're unable to understand the meanings of the words that we're speaking. So any words that are spoken are just going to sound like gibberish. So that will conclude our lecture video for chapter 16. I will see you all in the next lecture video when we will discuss the special senses in chapter 17.